Hello, good evening, students. This is Dr. Kunaal Agrawal, your original guru for the subject of orthodontics. So, in this session, we'll be discussing the questions which have been asked in NEET GT4 examination, right? So, without much ado, let's start with the first question. So, the question was, among the following, which is not a derived cephalometric landmark? So, you have to put consideration on two words here, which is not and which is a derived cephalometric landmark. So there are anatomical and constructed landmarks. So derived landmarks means they are asking about the constructed landmarks. So options are sella, PTM, that is PTM point, pterygomaxillary point, articular, or orbital. So these are the options. So before coming to the right answer, let's discuss about what are the landmarks and the measurement points in a lateral cephalogram. So we have sella turcica in the middle of the body of the sphenoid bone. Then we have spheno-occipital synchondrosis. We have basion. Basion is the junction of the foramen magnum and the posterior point of the greater wing of the sphenoid bone. Then we have Bolton point. Then we have porion. Porion is the superior most point on the external acoustic meatus. Then registration point. This is important from the point of view of cephalometric superimposition. In what we have to compare the before and after changes, whatever have been brought about by means of orthodontic appliances. Then we have orbital, that is the lowermost point on the outer margin of the bony orbit. Then we have pterygomaxillary fissure, which is present at 11 o'clock position. Actually, there are two schools of thoughts. One is the 11 o'clock position of the pterygomaxillary fissure. This is the PTM. So one school of thought says that the PTM point is somewhere over here, whereas the other school of thought says that the PTM point is somewhere at 6 o'clock position. So both are right, but for simplicity's sake, we'll take the PTM point to be present at 6 o'clock position. Then we have articular. Articular is the junction of the of the basi-occiput with the posterior surface of the ramal border. Then posterior nasal spine, antenasal spine, point A, also known as subspinal. This is point A, that is the deepest point on the concavity, present just below the antenasal spine. Similarly, point B, that is the deepest point on the concavity, present above the pogonion. Then pogonion is the anteriormost point on the bony protuberance of the chin. Then nathion. Now nathion is a constructed point. Menton is the inferiormost point on the bony chin. And gonion, this is again a constructed point, right? So options were, which is not a derived cephalometric landmark. So question is asking which is an anatomical landmark. Which is an anatomical landmark, right? So the options are sella, PTM, articular, or orbital. So the correct answer, the most appropriate answer in this question will be orbital. So anatomical landmark, that means we are talking about the anatomical landmark, not the constructed landmark. Although all of them are anatomical landmarks, sella is an anatomical landmark, articular, PTM, all of them are anatomical landmarks. But for simplicity's sake, for marking the correct point on the lateral cephalogram, orbital is the most easily marked point. That's why for this question, option D is supposed to be one of the most correct, most appropriate answers out of the following options. Then next question, all of the following cephalometric analysis reveal the severity of anteroposterior jaw dysplasia except. So question is asking which of the analysis reveal anteroposterior skeletal discrepancies. So for in Downs analysis, yes, we can make sure whether the patient is class 1 or class 2 or class 3. Steiner's analysis also. Witt's analysis, of course, that can be. But question is asking except. So Tweed's analysis is analysis which does not reveal the severity of anteroposterior jaw dysplasia. Now, what is Tweed's analysis? So it's a Tweed's diagnostic triangle. That's what it is called, by Charles Tweed. So Charles Tweed on a lateral cephalogram, he drew a triangle. Like this. So it has got three components with it. First is a Frankfurt mandibular incisal angle. That is Frankfurt mandibular incisor angle. Frankfurt mandibular incisal angle. So that shows the inclination between the long axis of the central incisor of the lower and the Frankfurt horizontal plane. So first component is this. Second component is incisor mandibular plane angle. This one. So which shows the angular deviation between the long axis of the lower incisor with the inferior border of the lower of the mandible. So that is incisor mandibular plane angle. And the third component is Frankfurt mandibular plane angle. This angle. This is Frankfurt mandibular plane angle. That's the angle between the Frankfurt horizontal plane and the mandibular plane. So Trees analysis is composed of three angles, and it does not show the severity of anteroposterior dysplasia. All it can show is the severity of proclination of the lower anteriors, and based on the severity of the proclination of the lower anteriors, we have different prognosis. So the incisors which are more proclined, they have got little questionable prognosis, whereas the incisors which are more upright on the basal bone, they have a lesser tendency of relapse. So we have a better prognosis towards the end of the treatment. That's what Tweed's triangle is all about. Next question is, the appliance shown in the figure is used to treat. So options are anterior cross bite, open bite, deep bite, or tongue thrusting habit. So first of all, we have to understand what appliance is this. Without a doubt, this appliance is a Catalan's appliance. Now, Catalan's appliance is an acrylic appliance, but for those uninitiated, any appliance which is acrylic in nature need not be removable all the time. So you might have preconceived notion that any appliance which is made up of acrylic, it can be removed by the patient. Although it is true in maximum number of appliances, but this statement does not hold true for this very particular appliance that is called Catalan's appliance. So Catalan's appliance, although it being an acrylic appliance, it is fixed appliance. It is cemented onto the lower anterior. It is cemented onto the facial surfaces of the lower anterior region. So if we draw a cross section of this appliance, this is the lower anterior. So this appliance is cemented onto the lower anterior, which has a 45-degree angulation. So this 45-degree angulation allows for forward proclination of the upper anteriors, which are originally in crossbite. So this 45-degree angulation acts as a guide plane. It acts as a guide plane which allows the forward proclination of the upper anteriors, hereby correcting the anterior crossbite. Okay, so that's what Catalan's appliance is all about. So it is used to treat anterior crossbite. Okay. Next is, in disturbed nasal breathers, the tongue position is. Now, disturbed nasal breathers, the question is hinting that the patient is originally a mouth breather. That's why it's called a disturbed nasal breather. Okay, so in mouth breather habits, in patients having mouth breathing habit, you must have read about in your lectures, in your colleges, as well as I have also mentioned in my previously recorded lectures as well, that in mouth breathing habit patients, buccinator mechanism is disturbed. The functional, in the chapter on functional development, I've told about the physiology behind buccinator mechanism and the clinical application of the same in a very comprehensive manner. So those who are not well versed with this mechanism, they can very well go back and refer to the chapter on functional development earlier, which has been taught to you earlier. So coming back to the question, in oral breathers, the tongue position is. Now this is based on a theory known as compression theory. So what does it say? So patients who resort to nasal breathing naturally have chronic nasal obstruction. That is why they are resorting to oral breathing, because breathing through the mouth, it obviously provides lesser resistance to airflow. The patient does not have to expend larger energy into respiring of the air, into inhalation of the air, right? So whenever we have chronic nasal obstruction, mouth breathing and head extension is what's the result, which happens involuntarily. So the head is extended on the shoulder girdle, on the clavicle, in order to further reduce the airway resistance, right? Then consequently, the mandible and tongue are kept in a slightly lowered position. Okay. Now because of that, there is increase in the lower anterior facial height. Because of that, the posterior teeth have a tendency of supra erupting because the freeway space is increased. Because of that, there's a tendency of development of anterior open bite and increased overjet. Now, there's disturbance of buccinator mechanism, as I mentioned earlier. Buccinator mechanism is a mechanism which holds the teeth in place. We have the tongue in the middle and we have the musculature surrounding the entire oral cavity. The buccinator muscle, the anterior part of the orbicularis oris muscle. Posteriorly, if you go, we have superior constrictor, and all these three curtains of the muscles are all together. They are opposed by a single muscle in the mouth that is called the tongue. So if the tongue is kept in a slightly lower position, so lower positioning of the tongue is what results in disturbance of the buccinator mechanism. Because of that, there is increased centripetally directed forces from outside of the three muscles, specifically the buccinator muscle, which causes collapse of the maxillary arch posteriorly, leading to development of posterior crossbites. Okay, so there's increased cheek pressure, and hence we have collapsed dental arches, leading to development of posterior crossbites in the maxillary region. This is what compression theory is all about. Now, this is again a diagram. It shows tonsils. It shows enlarged tonsils in the patient's mouth, in the patient's oropharyngeal region. So because of the tonsils, there is increase in the airway resistance. The patient has a tendency of keeping the tongue in a forward position, and also the patient has a tendency of keeping the head slightly extended onto the shoulder girdle. Now, because of this, the mandible has a tendency of moving down. It has a tendency of going downward and backward. That increases the lower anterior facial height, and all the results and whatever we have seen in this particular slide, that's what happens. So in disturbed nasal breathers, the tongue position is downward and retracted. Okay. Next is the permanent maxillary first molar of an 8-year-old patient is extracted because of caries. The approach to manage the situation is, now the question is asking permanent maxillary first molar of an 8-year-old patient. So the patient is 8 years old. That means the second molar has not yet erupted. They might be developing in the bone, but they have not erupted as yet for an 8-year-old patient. Now, the approach to manage the situation is place a space maintainer, surgical repositioning of the second molar, wait for the second molar to erupt and drift mesially into the extracted space, extract the contralateral maxillary first molar to maintain the integrity of the midline. So out of the 4 options, I think option C is supposed to be the most accepted option clinically. That if you extract the first molar prematurely due to whatever reason, we can wait for the second molar to erupt and drift mesially into the space, so that the second molar can be converted into first molar, and the third molar, which will develop even later on, can erupt into the place of second molar. So that is not going to disturb the occlusion of the patient. Okay. Next is in serial extraction procedure. The most critical observation is during the eruption of which tooth? So options are primary second molar, permanent maxillary molar, permanent mandibular canine and first premolar, and permanent mandibular incisor and the canine. So in serial extraction, we have got Dual's technique, and Nance and Tweed's technique. So Dual's technique resorts to the extraction of deciduous canine, followed by early extraction of deciduous first molar. This is followed by early extraction of first premolar. Now, serial extraction procedure is a very technique sensitive procedure. You have to be knowledgeable. You have to do all the necessary investigations to ascertain that whatever tooth you are extracting therapeutically as a serial extraction procedure, those teeth are going to be replaced by the permanent dentition at all costs. So you have to have an X-ray, you have to have the model analysis in place, and you have to undertake all the essential diagnostic procedures which are taken as standard for all the patients. Right? So Dual's technique is Series 4 and Nance and Tweed's technique is DC4. That means early extraction of deciduous first molar, followed by early extraction of first premolar, followed by early extraction of deciduous canine. So based on this, the most critical observation is during the eruption of permanent mandibular canine and the first premolar. Alright. Next is the mechanical methods of proximal stripping includes. Now proximal stripping is one of the methods of gaining of the space in an orthodontic patient. Whenever we come across mild crowding, and based on model analysis, it is concluded that this mild crowding can be corrected by means of simple proximal stripping. In that condition, we have different methods of undertaking the same procedure, undertaking this clinical procedure. One of the method is mechanical methods. So mechanical methods include ortho strip systems in contra-angle shuttle head, stripping with discs, stripping with files, or all of the above. So the correct answer will be all of the above. So mechanical methods, and we have one is mechanical method and another is manual method. So this is manual method and rest of the three are mechanical methods. So in manual method, as you can see in this figure, the operator is holding the double-sided diamond strip in his hand, and the orthodontist is putting the strip. He is basically removing the contact point. He's basically breaking the contact point between two adjacent teeth in a to and fro motion. So that is manual method. Rest of the three options, rest of the three figures, figure number 2, 3 and 4, they are on mechanical methods. That means we have resorted to using some mechanical instrument in order to bring about that particular proximal stripping. So that is why the three methods which are shown in the figure, they are mechanical methods, and hence all of the above will be the right answer for this question. We have other methods also. One is chemical method, in what we'll be etching with 37% orthophosphoric acid, plus it is followed by mechanical interproximal reduction of the enamel. And we have air rotor stripping as well. Although this method, the air rotor stripping, is not at all conservative. We have to have specifically designed instruments, specifically designed burrs, very thin, very sharp and very fine burrs, because air rotor stripping, I don't use it clinically in my practice, and so do not other orthodontists as well, because it is not at all a conservative procedure. It can remove a significant part of the tooth, and once the tooth is gone, once the part of the enamel is gone, there is nothing going back to it. Okay, so another method is air rotor stripping. And extensive study about air rotor stripping and the indications, contraindications, methodology has been well versed. They are very well documented in the literature by a person called Dr. John J. Sheridan in the year 1985. Next question. Which of the following is not an indication of distalization in the maxillary arch? Question is asking which is not an indication, right? Options are class 1 skeletal bases with a straight profile. This is definitely an indication. Mesial tipping of first molar due to premature loss of the teeth. This is again a very well documented indication for the same. Third is a class 2 molar or end-on relationship. This can also be an indication. Whereas vertical pattern of growth with open bite is definitely not an indication for molar distalization. You know what happens with distalization, as we'll see in the live classes later on. So with distalization of the maxillary arch, the maxillary molars, they have a tendency of slightly angulating slightly distally. Now because of that, the wedging effect comes into place. The upper molar is hitting against the occlusal table of the lower second molar. Now according to class 3 lever principle, if you have read the physics of the laws of physics in your elementary classes, 11th and 12th classes, you know what are there are 3 principles of lever: class 1, class 2 and class 3. So the stomatogenic system follows class 3 lever principle. So the more posteriorly you go, the more will be the effect in the anterior region. That's what class 3 lever principle is all about. So whenever we come across patients having vertical growth pattern along with open bite tendency, because of the wedging effect, we do not want to worsen the open bite effect. We do not want to worsen the vertical growth pattern of the patient by distalization of the molars. That is why in vertical pattern of growth with open bite, it's an absolute contraindication to distalize the molars. That's why out of the options, option D will be the correct choice. Our question number 9. Which of the following is an indication of therapeutic extraction of mandibular incisors? Now, just remember what can be the reasons of extraction of mandibular incisors. We don't extract it so often, but if we are left with no choice, then we may have to resort to extraction of the mandibular incisors. Options are deep bite cases with horizontal growth pattern. In patients where upper first premolars extraction is indicated with canines in class 1 relationship, lower canines are severely inclined distally and lower incisors are fanned out. And in patients with anterior discrepancy due to small lower incisors or upper large incisors. So out of the 4 options, clinically, option C seems to be the correct answer, where lower incisors are severely inclined distally and lower incisors are fanned out. So this clinical condition might be an indication that lower anterior segment has collapsed lingually. So that could be a reason to extract the mandibular incisors. What can be the other reasons? Whenever the lower incisor is severely periodontally compromised, or the patient has severe trauma from occlusion, traumatic bite, we have fenestration or dehiscence, or in case of severe crowding. In case of severe crowding because of discrepancy of arch length and the total tooth material. If you do the model analysis, it can be concluded that the best way to treat such patients could be by extracting the mandibular lower central incisor. Okay. Next up, which statement among the following is true regarding extractions? So if you see such questions, the entire chapter of extraction and the entire chapter of space regaining should open up in your mind. Okay. Options are: first molar extractions provide the maximum benefit in severe tooth material arch length discrepancy due to large space available after extraction. Next is removal of first permanent molars at the age of 11 to 12 years, facilitating the eruption of second molars is called Wilkinson's extraction. Well, this is okay, but the age of 11 to 12 years is wrong here. It is done much earlier. Third is first premolars are preferred over second premolars when there is tooth material excess of 4.5 millimeters in one of the arches. Now, according to Carey's analysis, this is wrong. So, whenever the tooth material excess of 5 millimeter is there, we prefer extraction of first premolars. So, it should be 5 millimeters. So, we have B and C as the incorrect option. Last is first premolars are extracted when there is space deficiency of more than 5 millimeters, as I said earlier. So the option D is the right answer. Now, if we talk about the first option, let's read it again. First molar extractions provide the maximum benefit in severe tooth material arch length discrepancy due to large space available after extraction. Here, we do not extract first molars. First molars are extracted only and only when it is not possible to save the tooth clinically. If it is extensively carious, if it has been restored endodontically in a not so acceptable manner, or if it is impacted, only in such cases we have to remove the first molars. Otherwise, all efforts are put in place to save the first molar, because it is rightly called the cornerstone tooth of the oral cavity. Okay, so instead of first molar, it should be first premolar. So out of the 4 options, option D seems to be the correct answer regarding extractions. During RME therapy, now this is quite interesting, the mid-palatine suture splits. You know, in RME, we have to split the mid-palatine suture. It splits in a parallel manner? Absolutely not. It splits widest anteriorly, diminishing posteriorly in this manner. Okay. In an hourglass shaped manner. Hourglass is like this. Does it split like that? No. And widest in the middle of the mid-palatal suture? No. So correct answer is, it splits in the anterior region in the widest manner, and diminishing posteriorly in this manner. So if you look at the maxilla in the coronal plane, this is the direction of opening of the intermaxillary suture, like this. So the lower part of the maxilla, the inferior part of the maxilla widens more as compared to more apical end of the maxilla. Similarly, in the axial view, when we place an RME appliance in the middle of the palate, this is how the mid-palatine suture opens up. So we have an inverted triangle. So this is the direction of opening of the mid-palatal suture, where you will see maximum opening around the incisor region and minimum opening around the posterior part of the maxilla. Now, why there is minimum opening in the posterior part of the maxilla? So answer lies in the buttressing effect of bones at the posterior maxilla, especially pterygoid plates of the sphenoid. So you know, the maxilla is articulated in a very complex manner. Maxilla being one of the key bones of the craniofacial structure, craniofacial skeleton. It articulates with a number of bones surrounding it, right? So as you go posteriorly, the complexity of articulations of the maxilla with the surrounding bones also increases. So it becomes nearly impossible for the maxilla to separate itself from the rest of the bones, and specifically the pterygoid plates of the sphenoid bone. So that is known as buttressing effect. So that's why the correct answer will be option number B, that is widest anteriorly and diminishing posteriorly. It opens up in this manner. Okay. Next is regarding rapid palatal expansion. The screw is activated at the rate of 0.5 to 1 millimeter per day, and force levels can build up to 10 to 20 pounds a day. This is the right answer. Expansion rate should be 1 millimeter per week, which will allow less amount of force buildup so that the patient experiences no pain during the procedure. Now this option, the second option, is valid for slow maxillary expansion, not rapid maxillary expansion. Third is, force level should be minimum of 100 to 200 pounds per day. 100 to 200 pounds per day. Imagine 88 kilograms. It's even more than the entire body weight. Do you even imagine, can that amount of force be tolerated by the teeth? Absolutely not. It should be 10 to 20 pounds a day, not 100 to 200 pounds a day. So a big no. The screw is activated at the rate of 0.5 to 1 millimeter per day, and the force levels can build up to 10 to 20 ounces per day. Now you have to look here that in the first option it is 10 to 20 pounds per day. In the fourth option it is asking 10 to 20 ounces per day. Now 1 ounce equals to 28.6 grams. Now just multiply 10 into 28.6 equals to 286 grams. Or if we talk about 20 ounces a day, so this will make a total of around 572 grams. Now is it enough? I don't think so. So the correct answer will be option A, that is the screw is activated at the rate of 0.5 to 1 millimeters per day, and the force levels can build up to 10 to 20 pounds per day. Now this is also written here. Read the first statement. It exactly matches the description given in the option above. And the expansion schedule is advocated by Zimring and Isaacson. There was one more person, that was Timms. So these three people have advocated the expansion schedule. What they say, that for young patients we have to go for 2 turns a day for 4 to 5 days and 1 turn a day for the rest of the treatment period. Whereas for adult patients, for the first 2 days we have 2 turns per day, and for the next 5 to 7 days 1 turn per day is given, and during the rest of the treatment period 1 turn is given every other day. Okay. Which of the following statements is correct as far as slow and rapid maxillary expansion is concerned? Now in this question they are asking about, in general, both slow and rapid maxillary expansion. Now the slow expansion moves the posterior teeth and buccal cortical plate buccally. Okay. Rapid maxillary expansion moves the posterior teeth and buccal cortical plate buccally. Both rapid and slow maxillary expansion move the posterior teeth and buccal cortical plate buccally. So I think option C will be the correct answer, because for both slow and rapid maxillary expansion, the forces whatever are supposed to be put across the mid-parietal suture, they have to go through the handles. Now the teeth act as the handle. The teeth and the alveolar bone, they act as a handle for transmission of the forces from the jack screw to the mid-parietal suture. So no matter if it is slow or rapid, the movement of the posterior teeth and bending of the alveolar bone of the buccal cortical plate is inevitable in either of the cases. So correct answer will be option C. Next is mild decalcification of the tooth enamel, that is clinical color change white to white yellow, is seen during orthodontic treatment. Which of the following is the most effective approach to prevent this? Now we have mild decalcification, that is the starting of development of white spot lesions has occurred. Now which is one of the most clinical effective method to prevent this? By using fluoride toothpaste without rinsing with water, using topical fluoride gel or rinse twice daily for 6 months. Third is, there is no need for any fluoride supplement. The decalcified enamel will remineralize on its own. Well, this is not the right answer. Option A and option B both are right answers. So option D will be the correct answer in this particular case. Okay. So this is the answer key in case you missed any question. So if you have got any doubts, you can ask me very well on Facebook and Telegram.